Hola, 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 hello and welcome. Welcome to my vet journey by Dr. Melissa Judah. Don't forget to subscribe and hit the bell. ¡Comenzamos! Now NSAID. For ECFEG CPE exam, you're gonna have two options, carprofen or meloxicam. Carprofen comes in a 50 mg per ml. It's an anti-inflammatory commonly used for post-surgery pain, but you need to give it 2 hours before the procedure to be effective. It's COX-2 specific, and the dose is going to be 4.4 milligrams per K sub-Q. Then we have meloxicam. It comes in a 5 milligram per ml concentration. It's a COX-2 preferential and prostaglandin synthesis. The dose is 0.2 milligrams per K IV or sub-Q on the first day, and then 0.1 milligrams per K once a day. If you give this medication and then you want to switch to another NSAID, you need to wait 5 to 7 days as a washout period. And this is due to the long half-life of the medication. Now we're going to talk about induction agents. For CPE examination, you're going to have propofol, alfaxalone, or ketamine. Propofol comes in a 10 milligram per ml concentration. It does not provide any analgesia. It's GABA receptors, glycine, and NMDA receptors. It lasts about 5 minutes, and it may cause apnea when given too rapidly. The dose is 2 to 6 milligrams per K IV slow. Then alfaxalone, it comes in a 10 milligram per ml concentration. Just like propofol, it can cause respiratory depression and apnea if given too rapidly IV. It has a high safety margin, and the dose is going to be 1.1 to 2.2 milligrams per K IV. And ketamine may come in 100 milligrams per ml or 50 milligrams per ml concentration. It is a dissociative anesthetic. It is an NMDA receptor antagonist, and the dose is 2 to 4 milligrams per K. It is usually combined with diazepam for its muscle relaxation properties. Maintenance agents are going to be inhalant anesthetics such as isoflurane and sevoflurane. I'm not going to go over this because I explained it in my previous video. But I'm going to leave here all the information. The most important part is calculate your MAC. That way you can give reasoning behind everything you do the day of your examination. If you don't know how to do it, please go to my previous video. Other medications that you are going to be able to use are going to be anticholinergics, such as atropine and glycopyrrolate, and Serenia. Now I'm going to give you some protocols with premedication induction combinations. Remember that for CPE procedures, they are longer than normal, so plan ahead. Protocol number 1 is going to be Serenia and carprofen 1 hour before premedication. Then for premedication, I'm going to use ace promycin and hydromorphone. Promising due to its sedative and muscle relaxation properties for up to 6 hours, and hydromorphone for its excellent pain control for up to 4 hours. For induction, I'm going to be using propofol 6 milligrams per K. A tip: calculate your higher end. That way you can keep some extra in your pocket in case your patient tries to wake up when transporting to the OR. Maintenance is going to be my inhalant anesthetic. Calculate your MAC. And as an emergency drug, I'm going to keep atropine in my pocket. I will use 0.04 milligrams per K just in case I'm faced with bradycardia and AV block. If this is the case, what I would do is that I'm going to give half of my atropine dose IV first, monitor the response and assess the patient, and then if needed, I will give the extra dose. The downside with this medication, with this protocol, is hypotension due to basically everything you're using, the propofol, promising, and the hydromorphone. Also, an enlarged spleen, which can make the surgery a little bit more tedious. But let's see an example of all of this. So let's use Maxa one more time. He is a 30-pound dog. So if I divide 30 by 2.2, I'm going to get his kilograms. That is 13.6 kilograms. So step number 1, control emesis and manage pain. So I'm going to do Serenia, and I'm using the 10 milligram per ml concentration. The dose that I'm going to use is the 1 milligram per K. So if max is 13.6 kilograms, I'm going to multiply that by the dose, which is 1, and then divide that by the concentration, which is 10. So I got 1.36 ml that I'm going to give sub-Q 1 hour before my pre-medication. Same thing with the carprofen. So for carprofen, I got 1.19 ml sub-Q that I'm basically going to give 1 hour before my pre-medication. Now, step number 2, it'll be sedation, muscle relaxation, and pain control. I chose to use promising and hydromorphone. So for promising, I'm going to use the 2 milligram per ml concentration. The dose will be 0.03 milligram per K. So if max is 13.6, I'm going to multiply by the dose, that is 0.03, and divide by the concentration. So max is going to need 0.2 ml IM. And then the hydromorphone, he will need 0.14 ml that I'm going to give IM. The step number 3 will be induction. And for that, I'm going to use propofol. As I mentioned before, I'm going to use my higher dose. With this, I got 8.2 ml IV slow. Of course, I'm not going to give it all, because if my pre-medication was really effective, then I won't need that much. But I'm going to keep the extra in my pocket. That way, if the dog's waking up while transporting or when the surgeon is pulling on the ovary, then I can give a little bit and be good. Then for maintenance, I'm going to use ISO, and I calculated my MAC. So for induction, I'm going to do 2.5, and for maintenance, 1.5. Then I also like to calculate my emergency drugs. In this case, the only thing you're going to have available is going to be atropine. Just in case I need it, I have it ready. Here is an example of another protocol. I will do Serenia and carprofen 1 hour before my pre-medication. Then I'm gonna pre-medicate with midazolam because it has sedative and muscle relaxation, and butorphanol, which is a good pain medication. For induction, I'm gonna use propofol. Again, try to calculate your higher end to keep that extra with you. I'm gonna maintain with inhalant anesthetic. I'm gonna calculate my emergency drug, in this case atropine. The downside with this protocol is that butorphanol only lasts 1 hour and has moderate pain control. So you may want to split this total dose. So you may want to give 0.2 milligrams per K as a pre-medication and then 0.2 milligrams per K right before your surgeon pulls on the ovary. Here I'm gonna leave some AHA anesthesia combinations and I'm gonna leave the link down below for you in case you want to see some extra information or other combinations. Possible complications during anesthesia. What would you do? For this part, I'm going to ask you to look at one problem or complication, then stop the video, think about what would you do, and then replay the video to see the answer. Let's start. Your dog keeps waking up. What would you do? So the first thing you're going to do is that you're going to check the leaks in your anesthesia machine and you're going to check that all tubes are connected properly. You want to check that your ET tube is in correctly. You're going to check that your inhalant anesthetic container is filled and that your oxygen tank is full and open. If your patient is hypoventilating, then you need to start breathing for your patient. Or it may just be that your patient is too low on gas anesthesia, so you may need to adjust your MAC. Hypoventilation. What would you do? Hypoventilation is when your CO2 measures more than 55 millimeters of mercury, you see brick red mucous membranes, and your SpO2 is less than 94%. This hypercapnia is usually due to stimulation of the sympathetic nervous system, increased cardiac output, increased contractility, vasodilation, and compensatory tachycardia. Medications like methadone can cause this. Also, if your patient is overweight or if there's too much pressure on the chest. An example of this is when we tie the front legs too tight so the chest cavity cannot expand properly. A mass in the chest cavity can cause this for the same reason. Your patient may be too deep or your CO2 canister is exhausted. The first thing you have to do is decrease your gas anesthesia. Then you're going to breathe for your patient at a 15 to 30 breaths per minute. If apnea happens, then you need to treat that immediately with intermittent positive pressure ventilation. Because if you don't correct it, then it may result in hypoxia, then respiratory acidosis, and then death. If you are faced with a patient that is presenting with hypoxia during your anesthesia, what would you do? Hypoxia is when your SpO2 measures less than 98% or your partial oxygen is less than 60 millimeters of mercury on your blood gas. Possible causes may be due to a low oxygen flow, so you need to check for a disconnection between the machine and the patient, or maybe that there's not enough oxygen, or that the oxygen tank is closed. Other things may be causing it as well, such as pulmonary disease, like pulmonary embolism or atelectasis, a shunt, or maybe your patient is too deep in anesthesia. The first thing you're going to do is that you're going to check your SpO2 probe placement, make sure that is corrected. If you want, you can also change the location of the probe and get another reading. You're going to check your oxygen source, and you're also going to breathe for your patient. If within a couple of minutes you aren't able to correct the hypoxia, then you need to start looking for other causes like pleural disease or parenchymal disease. Hypothermia, what would you do? Hypothermia is when the temperature falls below 99 Fahrenheit. It may be due to clipping or maybe when you're prepping for surgery, also induce vasodilation by anesthesia, cold fluids, or heat evaporates from respiratory system and an open body cavity. So to manage this, you can use heat devices such as a heat pad or a bear hugger, and you can use warm IV fluids. Hypotension. This is one of the most common complications that you're going to be faced with. So do not panic. Think about it. What would you do? So, hypotension is when your blood pressure falls for systolic between 80 to 90 millimeters of mercury, for the diastolic below 40 millimeters of mercury, and your mean is below 60 to 70 millimeters of mercury. Before you panic, you want to evaluate other parameters such as CRT or peripheral pulses. You can also change the location of your blood pressure cuff and get another reading. If everything is telling you that your dog or cat has hypotension during anesthesia, then the first thing you want to do is low your gas anesthesia. After that, you want to give some IV boluses. You can use 5 to 20 ml per K depending on the patient needs. If this does not fix your hypotension, then you can lower your gas anesthesia and use an additional dose of opioid. That way, your patient anesthesia requirement is lower. If none of this works, then you can do a colloid bolus or you can use some positive inotropes medications. There are some medications that when you use it, it's going to be unavoidable to have hypotension. An example of this is going to be acethromycin, which causes dose-dependent hypotension. So as long as your patient is low but constant and stable, and your mean is not less than 60, you should be fine. You can try giving several boluses and assessing to see if that will be enough to correct it. Bradycardia and second degree AV block. What would you do? So this is more commonly because your patient is too deep. So the way to manage that is that you're going to lower your gas anesthesia and you can give atropine IV, half dose first to correct it. Now that we know all of this, it's time to get familiar with your monitoring sheet. I would encourage you to practice with this sheet every time you're practicing anesthesia in preparation for your test. That way, the day of the test, you're familiar with everything that is on this sheet and you don't go crazy. I would advise you that you monitor your patient every 5 minutes. Make sure you're always moving, not sitting down. That way, everybody sees that you're doing something about whatever could be happening. And then feel the most you can. With the anesthesia monitoring sheet, the most important part is that you want to see trendings. That way, you can predict how your patient is doing or may react during your anesthetic procedure. Okay, vets, so this is going to be it for today's video. Make sure you like, share, subscribe, and hit the bell. That way you can get notifications for the upcoming videos. Stay tuned because in the next video, we're going to be covering the induction, intubation, and initiation of anesthesia in the limited amount of time that you have to do that. I'm going to be giving you tips and tricks on how to accomplish this successfully. Make sure you follow me on our social media, and until the next video.